So the next section, we're going to talk about diagnosis and testing. First of all, who should be tested for diabetes? When we're assessing a child, who should we refer to the provider? When the provider's assessing that child, what triggers a test for diabetes? Any child with glucose in the urine, polyuria, weight loss, or failure to gain weight despite voracious appetite. So any of those things, they're really hungry and they're losing weight. They're urinating a lot. They have glucose in the urine. They should be tested for diabetes. Anyone with glycosuria should be tested for diabetes. Any metabolic acidosis, so patient comes into the ER, we don't know what's wrong with them, they do ABGs, they have a metabolic acidosis, they should be tested for diabetes. Now, most of the time when they draw those ABGs, they're also drawing a chemistry, so look at what the glucose is on that chemistry. If they have risk factors for type 2 diabetes, such as family history of being overweight or obese, lifestyle risk factors, sedentary lifestyle, lots of processed high carb foods or simple carbs, not as much whole grains and fresh fruits and vegetables. A patient who has had gestational diabetes or has had a history of giving birth to a macrosomic infant. All of those patients our index of suspicion should remain high. With the level of diabetes in this country right now, it should be on the table for just about everybody that we see. Okay, how is diabetes diagnosed? First of all, glycosuria, glucose in the urine, is suggestive of diabetes, but it is not diagnostic. Someone can't be diagnosed with diabetes just because they have glucose in the urine. If they have an 8-hour fasting blood glucose greater than 125, that's diabetic. A random glucose greater than 199, if they have signs of diabetes. An oral glucose tolerance test greater than 199 at the 2-hour sample. It's actually a commonly missed diagnosis. Rapid onset type 1 diabetes is more likely to be fatal because the symptoms are similar to flu or gastroenteritis. The first thing that someone may notice is nausea, vomiting, weight loss, and feeling bad. So if you have a kid who is vomiting, nauseated, and they're feeling bad, you might just put them to bed and try to keep them hydrated. If you take them to the ER, they might just try to hydrate them. They might not even draw very many labs because it looks like a stomach bug. I actually have a friend whose child went to Boy Scout camp and came home 20 pounds lighter, and he had complained that the food wasn't very good, and he came home with stomach bug symptoms. And about 24 hours later, he was being airlifted to a pediatric ICU, and they were concerned about whether he would survive because he had rapid onset type 1, and he was he wasn't where someone was consistently observing him because the camp workers don't really know him, and his parents didn't see him for that week to see the onset of what happened. So it can happen that rapidly. And what's going to cause that level, that rapid decline is the dehydration. Okay. In the next section, we'll start talking about management, and it may be broken up into more than one recording.